Gui, Win. Hi, everyone. My name is Andrew Dutcher. I'm a psychiatrist and a trainee and child and adolescent psychiatrist in Calgary, Alberta. And this is going to be my presentation on harm reduction strategies in youth. So just let me pull up my slides here and we'll get started. There we go. So you can see, there's our title. And just to do a bit of an introduction, as I already did a bit already, I just want to acknowledge the land that I'm on, including Treaty 7 out here in Calgary, Alberta. And I want to acknowledge the land where the conference is happening to, unceded Mi'kmaq and Wolastoq territory. I am myself Wolastoqey. My band is the Nagook First Nation, and I was born and raised in Fredericton, New Brunswick. A little bit more about me is that, I did my medical school at Dalhousie Medicine, New Brunswick. I was in the second graduating class. And I came out to Calgary to do my residency in psychiatry, which I'm complete now, but I'm just finishing up my child and adolescent psychiatry training, and I'll be done that in July of 2021. I'm also very proud of being a husband and a father of two amazing girls. And so that's been a really big deal for me. As far as disclosures go, I'm just going to move my screen down here. There we go. There's no financial incentives other than an honorarium for presenting today. And just a few other disclosures is that I will be using this presentation and Lit Review as my research project for the Child and Adolescent Training Program in Psychiatry at University of Calgary. I also have my own YouTube channel, Mental Wealth. It's in its infancy right now, but I will be posting this lecture and presentation on there as well. There we go. So just to give you all an overview of what I'm going to be talking about today and the different things we'll be going through is that we'll be talking about substance use in Canadian youth, and that includes with specifically with Indigenous populations. I'm also going to be looking at the psychosocial and brain development during adolescence. What is harm reduction? And the evidence for harm reduction strategies in adolescents and youth. And then at the end, we'll take a look at Indigenous and culturally informed interventions for substance use. So to get started, and just to kind of frame this part, that, substance use is an issue in youth in Canada. If we look at the Canadian Student Tobacco, Alcohol, and Drugs study in 2019, we can see that 3% of people were in the youth category were considered to be smokers, and almost 1% were using daily. The age at when they first started using cigarettes was averaged around 13.7 years, so it's pretty young. More interestingly, we've got e-cigarettes becoming more popular nowadays, and we can see that in the stats where 20% have used an e-cigarette in the last 30 days, and 40% of those are using it daily. So it's a really big, and it's getting even bigger lately. 90% of those that are using e-cigarettes are using nicotine, so it's not like they're just using grape flavored juice because of the flavor. There is usually nicotine in these substances. We also see that the people that are using e-cigarettes are different than the people who are starting to use cigarettes. Quite a few of them have never touched a cigarette prior to smoking an e-cigarette or using an e-cigarette. And then out of those who have used both e-cigarettes and cigarettes, we've got almost half of them trying vape first. So it's almost a bit of a gateway into using other substances. So, this is lecture on harm reduction. And so if we're going to look at the harm reduction, we need to know what the different risks are. And with regards to the risk for smoking, these are quite well known, lots of literature on the risks associated with this. It includes nicotine addiction, COPD, cancer, cancer of the mouth, ulcers and gastric cancers, throat cancer, skin damage, heart disease, psoriasis, wrinkles, and cataracts. And so you can see our lovely lady here on the side. And yeah, just trying to give youth a bit of sense of urgency to not smoke anymore and show them what could potentially be some of the harms if they continue smoking as a youth. Initially, vaping and using e-cigarettes was seen as a bit of a harm reduction strategy in and of itself, but as with anything, it also has its own risks associated with it. And 90% of youth are using nicotine, and that is what people get addicted to. And so people are getting addicted to that. And the interesting thing about youth using e-cigarettes and vaping is that they may not need as high doses in order to get addicted, as their brains are still developing. And so this alters their brain development. It can cause poor memory and concentration, cognitive issues and problems. We're also seeing some poisoning from nicotine and potentially deaths, especially in the situation where young children have gotten a hold of the vape juice and have drank that. What we don't know about vaping is that how is it going to affect people down the road, and the long-term effects of both using it yourself or secondhand vapor. It has been theoretically linked to what's called popcorn lung and can destroy some of the lung tissue. And another interesting one is that devices have malfunctioned for people in the past, and we see that they've exploded in people's faces and have caused some injury that way. If we're going to take a look at the stats on cannabis, we see that 44% of youth have used cannabis, which is quite a high number. And if we're looking at use in risky situations, we see that 6% of them have used before school regularly or at school. And 5% of those have missed school because of cannabis. So that is quite a big issue for young people. 19, and to look at other risky behaviors, we see that 19% of those who are using have used cannabis and driven along with alcohol in the last 2 hours before they drove. So quite significant issues there. And you can just see the stats from that study to show how prevalent our use is and how kind of stable it's showing from the purple of 2019 to 2020, where it's basically staying the same. And yeah, if we look over here, we're seeing a few more males using than females at this time. If we're going to talk about the risks associated with cannabis use, we can see that there's mental health and educational problems, and affecting motivation, concentration, things like that. Dependence may develop, and young people can develop cannabis use disorder or cannabis dependence, just like adults can, and it can become a significant issue that causes problems in their life. Just like we said on the last slide, where they're either using at school or missing school because of their use. We also see people having injuries because of their use, getting into motor vehicle accidents, having some damage to the tissue in their lungs when they're smoking. Intoxication can especially be an issue with edible sources of cannabis, where the effects of the THC are quite delayed when it's absorbed through the gut. And we also see risk of psychosis, which is of big importance to myself and other psychiatrists who are trying to prevent people from having that first episode of psychosis. And we talk a lot about people who have either a family history or a personal history of psychosis to avoid using marijuana or cannabis. It's been linked to suicidality, and when used in pregnancy, it's led to perinatal complications, including low birth weight and growth reductions. Another interesting one, this hasn't necessarily been reported with cannabis itself, but with the synthetic cannabinoids, sometimes called spice or other things, there have been reports of death. As far as alcohol goes, it remains the most common use substance used by students in Canada. We've got 44% of students using it. And similar to tobacco, it starts around age 13 as the average. So some a little bit younger, some a little bit later. 23% of those who are using were drank in a risky way, where they're using even above the adult recommendations for limits, which would be, for males, 4 drinks or less in one sitting. So that's pretty concerning. We've also got people using energy drinks and alcohol on the same occasion, about 16%, which presents its own risk where normally if you drink too much alcohol, it would kind of cause someone to black out or pass out. But because they're using the energy drinks, it gives them more time awake and more time to consume more alcohol to toxic levels, becoming even more dangerous. And if we look at this is something that I didn't know too much about, these sweetened high alcohol content beverages. About 19% of youth have tried those, and they can sometimes be up to 11% of alcohol. As you can see here, I've given some examples. We've got Four Loko over here and some Club Tails, and this one up here as well, as things that people have tried and kind of use to get intoxicated. Risks of alcohol get broken down generally into short-term and long-term risks. With regards to the short-term, you see things like motor vehicle accidents, falls, drownings, violence happens, people getting, attempting suicide, homicide, sexual assaults. We get people with alcohol poisoning, and like I said, when it's combined with the energy drinks, a little more prevalent with that as well. And you are also seeing risky sexual behavior, where people are putting themselves, not using the same protective behaviors that they would when they're not intoxicated. Use in pregnancy can lead to miscarriage and stillbirths and fetal alcohol syndrome as well. The long-term risks, if people drink chronically and on a daily basis, can lead to all sorts of health outcomes, including high blood pressure, heart attacks, strokes, liver disease, cancers, decreased immunity, dementia and cognitive problems. We know that it is a depressant, so it leads to depression, worsened anxiety, and can lead to lots of social problems, which is what we would see with alcohol use disorder. We, take a look at the opioids use in this age population. We see that about 3 to 8% are using opioids, and that it's not as high as other substances, but in fentanyl, which can be especially dangerous in those who have never used it, is increasing in its use and has gone up from 0.5 in 2016-17 to up to 2 or 0.7% in 2018-2019. If we see the stats on First Nations youth, we see that it is higher at 10% than the 8% above. Harms associated with opioid use include poisoning, where they become quite unwell from that and can end up having all sorts of negative health outcomes, including hypoxic brain injuries. And there's also adverse drug reactions, allergic reactions, things like that. And being exposed to chemicals in those drugs, when they're not pharmaceuticals and more illicit drugs, they can put other things in those drugs as well. There's motor vehicle accidents and what's called neonatal abstinence syndrome. When a child is born to a mother who's been using, this child can experience significant adverse health outcomes when the child is born and is withdrawing from opioids in that first period. Deaths, which is a big one, and that's kind of been driving the concerns around the opioid epidemic, especially out here in Alberta. And they've been working really hard to try and minimize the risks associated with risky use. which is happening usually accidentally in males. Just to talk a bit more about those deaths associated with opioids, we've got 70% of those usually involve something else like alcohol, benzos, cocaine, or meth. 80% of the fentanyl overdoses also include those substances. And so combining them is especially dangerous. And if we look at First Nations populations, we see that they're 5 times more likely to have an overdose and 3 times more likely to die than non-First Nations people. Especially concerning. And if we look at the stats otherwise on First Nations use, we see that 23% of grade 5 to 8 have tried alcohol, 14% have tried cannabis, and overall First Nations just have a higher odds of using. That's not to say why, it's just what they've noticed in the studies where, in drinking cannabis and smoking, we get much higher rates. Indigenous rates are dropping less drastically than non-Indigenous rates. And it's been shown that Indigenous youth are exposed to more secondhand smoke than non-Indigenous youth. Here's just another graph from a study that was done out of Lethbridge University, which shows the rates of prescription drug abuse and shows that it's quite a bit higher than non-Indigenous populations. So moving on to adolescent development, we want to adolescence is a unique period of time where kids are transitioning into adulthood, and part of that transition is where kids are developing stronger peer relationships. They're learning to make decisions on their own and learning to consolidate and synthesize information for themselves. They're also pursuing things that they're interested in, their interests, they're forming their identity and trying to figure out who they are and where they fit in the world. We also talk about how there's 3 expected developmental changes during that time, where we see that there's an increase in risk-taking, there's increased sexualized behavior, and there's a move towards associating themselves with their peers more than their family of origin. This is Eric Erickson here, who's a thought leader when it comes to developmental stages, and he talked about the different developmental tasks at various developmental ages, and he identified adolescence as a time of figuring out one's identity, and the task was to identity versus role confusion, where he noticed teens had to figure out who they were in order to kind of go on and get through that developmental challenge at that period of time. He said failure to do so may lead to confusion about one's role, delinquency, and gender-related issues, and borderline psychotic episodes. If we look at some other aspects of adolescent development, we see that impulsivity and sensation seeking is going up during adolescence. And although risk-taking is a necessary endeavor, doing things like problematic sexual behaviors or using drugs to fulfill those developmental tasks, it can lead to long-term serious health consequences, or death in some cases when it comes to things like fentanyl. So yeah, I've just put a couple graphs here, like the one over here showing sensation seeking kind of peaking around 18 to 19. That comes along with that impulsivity. And then this other one just kind of showing a bit of a directional pathway towards how kids come to use alcohol, where they're seeking those positive sensations and they're wanting that positive reward. And all of the people around them may be using them, and that's also increasing the chances that they're going to be using as well, as that's giving you not only some biological, psychological, but also social rewards to continue use with alcohol. So we can see that adolescence is a period of time which is high in risky behaviors, and it's kind of combining all those facts together makes it more challenging to engage people with reducing some of those risks. And one of the other reasons I wanted to tie in that can be challenging is because of the brain development during that period of time. We see that judgment is the last thing to develop in adolescence, where we're looking over here at the 5-year-old brain, where the dorsolateral prefrontal cortex is quite underdeveloped at this time, which is normal. And as we progress through time, it starts to become more and more developed, and they develop judgment and kind of move through life with their brain developing in a more healthy way. So just to talk briefly about the neurobiology of substance abuse, looking at the different structures in the brain, there's some of the main structures that we have include the ventral tegmental area, the nucleus accumbens, and the prefrontal cortex, but also the hippocampus comes along with that as well. The nucleus accumbens has increased levels of dopamine, that feel-good substance, in addictions. And I'll talk a bit about that in a second. But what happens is that that in conjunction with the hippocampus, or where the memories get stored, it starts to associate those good feelings with substance use. And therefore it kind of modulates the response by that pleasure center, the nucleus accumbens. What we see too is that the prefrontal cortex starts to make links between those cues in the environment and the emotions, and starts to become trained to see those things as a sign that the substance is coming, and they start to anticipate use and anticipate wanting to use. And then as they go through that process more and more, the repeated effects of doing those behaviors, it increases the strength of those circuits, and they start to fire more effectively, and the behavior happens more smoothly and quickly without the person really thinking about it. There is one theory here where it's the stress incubation corticolimbic developmental cascade hypothesis, which is a big term to basically explain that, due to childhood adversity and stress, it typically leads to a change in the hormones, and can cause dysregulated stress responses in the body, leading to higher levels of cortisol, that stress hormone. And exposure to stress during those sensitive periods, it alters kind of our ability to remember those events in our hippocampus. It also increases dopamine in the nucleus accumbens, making it harder for us to experience pleasure when the nucleus accumbens has that higher level of dopamine already there. So you need even more dopamine to start feeling good. And that's why people seek out substances during those, with that kind of biology. There's also decreased growth in the prefrontal cortex and synaptic pruning during adolescence. So they are having less of the brakes involved to stop them from doing those things. And that part of the brain is making associations with those environmental cues more easily as those things, as those cues become more reinforced, and they continue to do them more and more. Another interesting fact is that there's a certain level of brain maturity that is required in order for these things to present themselves. As in adolescence, there's the greatest number of dopamine 1 receptors in that prefrontal cortex, or that higher order part of the brain. And it doesn't, and the stress early in stage is theorized to activate more of that and make it harder for the brain to control itself from substance use later on. So what is harm reduction? And so briefly, harm reduction is an evidence-based, client-centered approach. And one of the main goals of it is to reduce the harms associated with certain behaviors at any point in life. It's not particular to adolescence, but it could be harms with regards to the health, or interpersonal harms or social harms. Non-judgmental and non-coercive strategies, they help people make that choice about how am I going to engage in my own health care, and it empowers the individual through that process. One of the main things is to try and teach new skills, communication skills, assertiveness skills, and coping skills to help that person combat their desires and urges to use substances. And it's a strategy that's used when abstinence or reducing their use may not be possible. So it tries to meet people where they're at, and with harm reduction, it exists on a spectrum, and so it could involve abstinence could be part of that spectrum, but also ongoing use and just harm reduction, trying to not have them get an infection like hepatitis C or hepatitis A from sharing needles or something like that. Some examples of harm reduction include things like pretty common examples like using a helmet or wearing a seatbelt when you're driving a car. But it could also include things like needle exchange programs or opiate agonist therapy. And the other thing, like other common examples would be things like nicotine replacement therapy. Now, to talk about some of those interventions, I figured I'd start off with a bit of an abstinence-based approaches and talk a bit about those approaches, because that's traditionally what has been promoted in the schools. As I remember myself actually, seeing this lion and having the cops come in and show us the drugs and tell us the drugs are bad and don't do them. And what the studies have shown over and over again is that there's a lack of effectiveness with these strategies, and that they just don't work. Where you've got someone in front of a class just telling you don't do it, people generally don't listen to that. There is another program called Keeping It Real, very cool name, but it's more culturally grounded. And it tries to engage youth with trying to learn skills and develop more of an interactive understanding of drug use and how those harms can affect them. Still, there's some benefits to that strategy. However, the studies on that strategy are quite poor as well. And so it's limited the effect that we can assume from that. Now, if we are to look at kind of not the abstinence-based programs and more of the harm reduction approaches, they get broken down into generally three main categories that I saw were mostly studied. And that's school-based interventions, family-based interventions, and multi-component based interventions. And if we're to take a look at school-based approaches, so it's just strictly curriculum in the school. They're teaching kids about skills, skill rehearsal. They're doing workbooks, working on things, and having those discussions in the classroom with the goal of minimizing harm. They've studied this quite a bit, and it seems like, still the study quality is poor, and there's not much benefit from a strategy where you're just engaging in the school. They looked at following up, like if people had the intervention and then a year later, 2 years later, to see if they still had that knowledge or maybe had reduced their drinking or smoking. A year later, they found that those rates went right back to the baseline that they were before. There was also a really large study done on these types of interventions, and it found that there was limited benefits and in high risk drinking. So there's a bit of a reduction there, but the quality of the studies was still quite poor. The next approach was that family-based one, where they were engaging in individual and family therapeutic and educational sessions, trying to develop skills and improve communication between the youth and the parents. And there's quite a few studies looking at those methods. And unfortunately, because all of the studies were so kind of varied in how they were done, and they didn't really report their substance use outcomes as consistently, it was really hard to make conclusions about whether or not this is an effective strategy to reduce substance use in youth. Yeah. Also with that big review that they did, there was significant reductions in alcohol misuse, but the studies were quite poor quality, and it made it hard to draw firm conclusions about that. The next one was the multi-component strategies, where this usually included some type of intervention in the school where they were giving the kids a curriculum about the harms associated with drug use and how to reduce their use and which skills to develop and how to develop them. But they also went into the home and they try to send strategies home to engage the parents, to talk with their kids about it, to teach those skills and teach the parents the skills as well. There was a bunch of different um, programs where they had the drug education in Victorian schools, the integrated program, Project Alert, Say Yes First. And Say Yes First was an interesting one. It was kind of the response to Just Say No to Drugs, where they were like, well, we just want to reduce the amount of use and really focused on that harm reduction piece. Interventions that used these strategies generally had a good, they had a significant effect. So there was a positive effect in reducing alcohol use and other substance use, which was most pronounced for like really severe like binge drinking or drunkenness. But they were, again, poor quality studies, inconsistently reported, and it was hard to draw any of those firm conclusions as well. One cool one here that I stumbled across was a study done on an app called Ray's Night Out. So you can kind of see a little red panda here who is wanting to go out for a fun night, and then in the other one he's taking a drink at the club, and so it's kind of cute. It's kind of fun to play. I checked it out. It was pretty neat, but the study that was done on it wasn't really, didn't show any really effect above and beyond the control, which was too bad. But if you want to go check the game out, it's pretty fun. It's kind of neat, and it's really based on that harm reduction and teaching kids about not to go over their line of getting kind of silly or drinking too much and making a fool out of themselves. The next one to talk about is more of an intervention, where we talk about brief interventions, which have been quite well studied in adults to reduce hazardous and harmful drinking, where it uses this framework, and so it's called the FRAMES tool for brief interventions, and tries to engage people with some concern about their drug or alcohol use to try and get them to reduce in that moment. And sometimes it includes a referral to treatment as well. But the FRAMES tool includes things like giving them personal feedback about their risk or impairment. This is you're drinking while driving, like you could easily get in a car accident. Responsibility for the change is in that person, and that empowering that person to try and feel like they can make that change. Giving them some advice to change, and offering a menu of treatment options to them is the M. We've got empathic style, and just trying to validate what's valid with the person and trying to support them during that period of time, and encouraging self-efficacy and optimistic empowerment. So although they've been well studied in adults and have good effect, unfortunately in youth there is low quality evidence for using behavioral or brief interventions for alcohol use, alcohol abuse, alcohol dependence, and cannabis abuse. So unfortunately it doesn't seem like they have as good an effect as they do in adults. And one study actually compared it to just providing information about substance use and found that a brief intervention was the same as just giving them information about the substance. One thing that we do know, and that was well studied, was that doing a brief intervention for tobacco in the emergency room was not effective, or in the hospital. And then we look at this last piece here, screening, brief intervention, and refer to treatment, or SBIRT. And it was found to have positive reductions in use and reaching out to get treatment, but there wasn't many studies in youth on that strategy yet. Yeah, and then generally speaking, most of the results are modest and the evidence is usually poor quality. So unfortunately, not the greatest. So if we look at Indigenous interventions for substance use, we can see that, you know, from what I saw in the literature, there are many different models out there. I tried to list them all right here. There's Healing of the Canoe, Living in Two Worlds, the Shadow Project, all sorts of things, all sorts of different ones, and even a cultural DBT, which I thought was interesting. But they included all sorts of things, including the features of programs that other ones had, but they usually added in a traditional activities component where that included smudging, ceremonies, sweat lodges, stories and legends to try and make the content relevant to people, crafts, drumming and singing, and wilderness outings. And although the substance use measures weren't really necessarily reported as consistently as you'd hope, they did report a lot of other things where we don't typically see in other studies, including things like hope, optimism, self-efficacy, assertiveness, and they usually saw improvements in that, including levels of cultural identity. Another interesting one had down here where it was like those who had an increased sense of ethnic pride had they usually more strongly stayed away from drugs and adhered to those anti-drug beliefs and norms. Just to wrap up here, I wanted to put in the Canada's lower risk cannabis guidelines and some of the recommendations over here. Just, you know, one of the main ones for youth is trying to delay initiation as long as possible, at least to more than 16 years old. And you've got all the other ones right there. And we've talked about avoiding use if there's a history or family history of substance use, psychosis, or being pregnant already. Also, Canada's low-risk drinking guidelines in 2018, they just updated those recently, and they increased the levels for men and women. Now it's at 10 drinks per week for women, 15 drinks for men. And if we look down here, they did provide some guidance with regards to youth as well, and said max 2 drinks twice per week and under parental supervision. So that's kind of where things are at with regards to alcohol use in youth and what they're recommending. So some conclusions and my main points include that substance use in adolescence is a problem. Adolescence is a risky period of time for biological, neurological, and psychosocial reasons. And that harm reduction is a way to meet people where they're at and try to reduce some of that risk associated with drug use and other risky behaviors. There are no well-researched harm reduction strategies in youth, and more research is needed and good quality research is needed for harm reduction strategies to figure out what is truly effective. So there are my references, and Leon, thank you. Any questions?